already know AD from Atmos. I already have connection to him. Maybe if Dr. Nofialdi wants want to have a T-tube, maybe more easily now. I ordered from Malaysia. But they have Montgomery.
Boston
T-tube.
Montgomery.
Yeah,
Yeah.
Montgomery.
Eddie di sini.
Yeah, Eddie. I have a contact from him. Okay, maybe Prof.
Visa bisa di share aja kontaknya, nanti kita bisa hubungi mereka.
Iya, Dok. Dan ada juga ini bisa dikirim juga sih Dok ke ini. Cuma mungkin dapat teks biaya cukai untuk itu.
Oke. Thank you.
Okay, Prof. Maybe from our department tells me that we just go on with the presentation. Good. Maybe I will be open this session. Good afternoon, ladies and gentlemen. Assalamualaikum warahmatullahi wabarakatuh. Welcome back to our 5th session of our invited professor webinar program. My name is Arviza Putra as moderator today. For brief introduction, this webinar was held by Otorhinolaryngology Head and Neck Surgery Department of Universitas Sumatera Utara. Our speaker, Prof. Marina Baki, was a senior consultant otorhinolaryngology head and neck surgery at the Hospital Tengku Mukhriz University Kebangsaan Malaysia, subspecialized in laryngology. She was awarded in PhD in laryngology from University College in London in November 2014. This morning, she will present the lecture about the unilateral focal fault paralysis and the surgical intervention, a very interesting topic, and I hope this topic will be useful in our clinical setting. If you have any question, please type into the chat board. Prof. Marina, time is yours.
Assalamualaikum warahmatullahi wabarakatuh. Salam al-hijrah kepada semua. Hari ini first day ya, New Year for the Islamic calendar. Thank you Dr. Arfiza for the kind introduction. Without further ado, let me share the slide ya. So the topic today is on unilateral vocal fold paralysis and the surgical interventions. Okay. So vocal fold paralysis, we have unilateral and bilateral. So for today, we are focusing on the unilateral vocal fold paralysis. And this is Faculty of Medicine, and this complex is the University Kebangsaan Malaysia Medical Center, which consists of the Faculty of Medicine over here. Over there is the hospital, and then there is a new building at the side here, which is not shown in this picture. We have a children's hospital, Hospital Pakar Kanak-Kanak. Okay, and go to the next slide. This will be the content of the lecture. I'm going to talk a little bit on some theory on the recurrent laryngeal nerve injury, then followed by what is the natural cause of permanent recurrent laryngeal nerve injury. You know that that would be neuropraxia and permanent. So in permanent type, what would be the natural cause? Treatments for unilateral vocal fold paralysis, and then I'm going to touch a little bit on each, on injection laryngoplasty, principle of laryngeal reinnervation, type 1 thyroplasty, and for each section I would show some cases, followed by conclusion. So for the introduction in recurrent laryngeal nerve injury, it can be due to iatrogenic, neoplastic, or idiopathic. Those are the common ones. Yeah, the less common ones are traumatic, what do you call that, neck injury, aortic aneurysm, radiation induced, and cardiovascular pathology. And of all these, the commonest is iatrogenic. And of all the surgery that may cause recurrent laryngeal nerve injury, thyroidectomy document the highest incidence. So the commonest in the following thyroidectomy, and the injury could be temporary or permanent. According to this systematic review in 2009, the risk of permanent recurrent laryngeal nerve injury is about 1 to 2%. However, it may be underestimated, because some cases may be missed the diagnosis. We may miss the diagnosis, or maybe it is not reported. Can you see my cursor moving? You cannot, right? Cannot. I think I have to stop. Okay, now it appears now. Okay, right. So before we go further on about recurrent laryngeal nerve injury, I want to bring you to go back to understand the anatomy of the intrinsic muscle of the larynx, which innervated by the recurrent laryngeal nerve. See, this is the laryngeal framework in axial view or bird eye view. And this is the posterior part, anterior part, right side and left side. Here we can see the hyoid bone, the thyroid cartilage, and the posterior lamina of the cricoid cartilage can be seen here. And below here you can see the shadow of the anterior lamina of the cricoid cartilage. So you see here, these are the intrinsic laryngeal muscles. We have thyroarytenoid, we have lateral cricoarytenoid, interarytenoid, and at the back here, from the posterior cricoid lamina to the muscular process of the arytenoid is the posterior cricoarytenoid muscle. So these intrinsic muscles control the movement of the vocal folds, okay, which the movement of the vocal folds together with the arytenoid, with the synovial joint, allow the movement of the vocal folds. I forgot to mention there's another pair of muscle which is the most superficial. Here you can see cricothyroid muscle. So all of these intrinsic muscle are supplied by the recurrent laryngeal nerve, in which in this recurrent laryngeal nerve, the main trunk consists of the abductor axons, which supply the thyroarytenoid, lateral cricoarytenoid, interarytenoid muscle, and some innervation to the cricothyroid. And within the recurrent laryngeal nerve, there is abductor axon that innervate the posterior cricoarytenoid muscle. And this pair of muscle is the only muscle that the contraction would allow opening of the glottis, abduction of the vocal folds. All right. And the cricothyroid over here is supplied by the superior laryngeal nerve, which is branch of the vagus nerve. That contraction of the cricothyroid muscle will allow the tensioning and lengthening of the vocal cord to allow high pitch, production of high pitch voice, like from the low tone. So when we go to high pitch, that is the effect of the contraction of the cricothyroid muscle. Okay, so that is just a recap on the anatomy of the intrinsic laryngeal muscle. So what happened when there is a recurrent laryngeal nerve injury, unilateral? The muscle of the larynx unilateral will be flaccid, immobile, and that would cause glottal incompetence. So you can appreciate here, the left vocal fold is immobile, the right vocal fold is mobile. So during phonation, there is a glottal gap because of the immobility and flaccidity of the left vocal fold caused by injury to the recurrent laryngeal nerve. So what happened when the nerve is injured? Like shown in this diagram. When the nerve is injured, okay, the nerve, the distal part will be separated from the soma, okay, the cell body. So what happened is the distal part will undergo Wallerian degeneration. There will be disintegration of the distal part of the nerve. With time, the axons over here would regenerate. This is the effect of proliferation of Schwann cells, and eventually when the distal part regenerate, eventually it will re-innervate the distal target muscle, okay, that possibly restoring function. However, it is not true for all type of injury. For if you look at into Sunderland classification, if you look into type 1, 2, 3, 4, and 5, if the nerve injury is type 3 to 5, although there is a regeneration, but there may be the end organ function may not return to normal despite effective regeneration because of phenomenon of synkinesis. So we're going to talk more about this synkinesis. So what happened in synkinesis is there is regeneration of new nerve, there is a re-innervation of the muscle, but there is the re-innervation occur aberrantly. So the contraction of the different muscle cancel out the mobility of the vocal fold. So now I'm going to talk more about regeneration and synkinesis of the recurrent laryngeal nerve. So as I said just now, recurrent laryngeal nerve comprises abductor and adductor axons, right? In the brain, okay, the neurons are separated by at the brainstem. It is separated. Okay, we can see clearly. If not clearly, but it is well separated, in which the abductor part of the neurons is located at the ventral division, and the adductor one located at the dorsal division. This is at the brain level, at the nucleus ambiguous. However, when the motor axons enter the peripheral nerve pathways, comes out from the brain, okay, the adductor and abductor axons, there's no clear separation anymore. Then the axons are, there's a mixed integration, or it is intermingled. Therefore, when there is a transection of the recurrent laryngeal nerve, when after Wallerian degeneration, and when there is a regeneration, okay, the new axons are not clever enough to choose the target muscle. So some regenerated abductor axon may go to adductor muscle, and some regenerated adductor axon will go to abductor muscle. So therefore, although the muscle is well toned, although there is a re-innervation of the laryngeal muscle, but there is no mobility because of this aberrant re-innervation. And this phenomenon is called synkinesis. So the target organ still could not get the normal function. So now, after we talk about the recurrent laryngeal nerve injury, regeneration, and synkinesis, okay, please ask if you don't understand any of this. We're going to talk about the natural cause of permanent recurrent laryngeal nerve injury. In temporary, maybe within 6 months, sometimes 1 month, 2 months, 3 months, the mobility may return. But some injury would be permanent. The mobility wouldn't return. So in the acute phase, okay, as I've shown in the previous video, the muscle of the denervated muscle will be flaccid. There will be big phonatory gap. The voice will be breathy, and the patient may have aspiration if the glottal gap is big. With time, following the acute phase, we wait for several weeks. The patient normally experience some improvement of voice. Okay, that is not because return of mobility, but commonly due to physiological compensation. I'm going to show you in this video a patient how does the laryngeal compensation look like. So this patient has left vocal cord palsy. Can you appreciate that? You know, the opposite side cross the midline. There's some muscle tension dysphonia to get closure. Okay, so although the voice is better, but the patient still have to do effortful voice production. Okay, the patient would still experience voice fatigue. Right, so this is a laryngeal compensation. So what happened if we wait for months? Okay, so if we wait for months, there would be two fates of the permanent recurrent laryngeal nerve injury. So either the vocal fold, the paralyzed vocal fold, had a spontaneous favorable position or unfavorable position. So this whether the patient have spontaneous favorable or unfavorable outcome would depends on degree on spontaneous reinnervation. After that, Wallerian degeneration, after that, regeneration of the new axon, okay? It would depends on how much the degree of reinnervation occur and how much is the synkinesis and whether or not the vocal fold receive any dual innervation from the external branch of the superior laryngeal nerve. The more the dual innervation, the less problem with the voice. Okay, so this video shows a patient who have spontaneous favorable spontaneous regeneration synkinesis, but with favorable position of the paralyzed vocal fold. So the paralyzed vocal fold is on the left side. This is the right side and that is the left side. Can you appreciate that? The left vocal fold is immobile, but there is no bowing, it is not flaccid, the arytenoid is nicely placed, and during phonation, although this is not mobile, but the opposite vocal fold can meet the paralyzed vocal fold easily. There is no supraglottic squeeze, there's no muscle tension dysphonia, and the patient does not have to put a lot of effort in producing voice. So in this condition, you may not, although it is paralyzed, you may not have to offer anything because the voice is good. If without looking the vocal cords endoscopically, people wouldn't know that the patient has unilateral vocal fold paralysis. So now we're going to talk about treatment in those cases whom suffer permanent unilateral vocal fold paralysis and the vocal fold position is unfavorable. So in this is a paradigm shift of management of unilateral vocal fold paralysis. Those days when ENT surgeons are referred cases of unilateral vocal fold paralysis, the plan is just observe, refer to speech language pathologists. If the patient have aspiration, put on RAS tube and send for swallowing rehabilitation. And the patient is observed up to 6 months. And if there is no recovery of function, then only surgical intervention is offered. But for current treatment, there is a paradigm shift. It's no more watch and wait for 6 months. Early intervention is recommended as soon as possible, and as soon as on table, you can offer intervention for unilateral vocal fold paralysis, because offering or giving early intervention in unilateral vocal fold paralysis, it gives better voice outcomes. It would prevent the larynx patient to develop muscle tension dysphonia, and the patient may not have to undergo permanent surgical intervention, although the vocal fold still paralyzed, and you also can avoid patient going home with nasogastric feeding. The patient can take orally without any aspiration. So what are the surgical treatment that we can offer for unilateral vocal fold paralysis? So just for revision, in surgical treatment of unilateral vocal fold paralysis, the optimum aim is to allow contact between the two vocal folds, between the normal side, the mobile side, and the paralyzed side. So hence, to close the phonatory gap, then the patient would have stronger voice and the patient wouldn't have aspiration. So what are the surgical options? Number one, you can offer injection laryngoplasty, which can be temporary or long-term material. You can offer type 1 thyroplasty or open thyroplasty with or without arytenoid adduction. Like we are going to touch a little bit on type 1 thyroplasty. And the other one is laryngeal re-innervation, non-selective laryngeal re-innervation for unilateral vocal fold paralysis. So this is algorithm in the treatment of unilateral vocal fold paralysis. As I mentioned, the paradigm shift, we don't wait after 6 months only offering intervention. We can offer on table as soon as possible within 6 months, at 6 months, and also after 6 months. All right. So this part is the paradigm shift, acute intervention in unilateral vocal fold paralysis. So I'm going to touch on injection laryngoplasty, which is one of the surgical option which you can offer as soon as possible, and even you can do on table, for example, in patients undergoing thyroidectomy, and nerve monitoring shows that there is signal loss one side, the nerve is intact, you can do the injection gel intraoperatively, so that when the patient wake up, there wouldn't be bad breathy voice and the patient wouldn't have aspiration. So in injection laryngoplasty, the material or injected is injected at the paraglottic space, okay, on the side of the paralyzed vocal fold. The aim of the injection to increase the bulk, to augment the paralyzed vocal fold. Hence, the opposite side during phonation would easily have contact with the paralyzed vocal fold. It can be done either transoral under general anesthesia or under local, transcutaneously or percutaneously. We're going to talk more about this after this. And these are the materials that have been recommended in the literature. You can use fats, bovine gelatin, collagen-based, hyaluronic acid, carboxyl methylcellulose, and a long-term material is calcium hydroxide apatite. The clinical effectiveness generally 4 to 6 months, and there is so far there is no high evidence to recommend which material is the best for you to use in treating this condition, unilateral vocal fold paralysis. So this is a paper which is published in 2018 on systematic review on early injection laryngoplasty. And from this systematic review, it gives an indication that if you offer early intervention, the voice outcome is better and the patient may not have to undergo thyroplasty, although the vocal fold remain paralyzed. So it is recommended for you to give the injection as soon as possible. So this is a diagram showing where we inject the material. So for example, if the paralyzed vocal fold on this side, on the right side, so the material is injected in the paraglottic space lateral to the vocal fold ligament. And this is a coronal view showing the needle goes into the paraglottic space lateral to the vocal ligament. This is the materials that used in our center. For short term, we use hyaluronic acid, and this is the brand. There are many other brands of hyaluronic acid, such as Surgiderm, and recently someone introduced Nuramis, but I have no experience using Nuramis as yet. And the other one for long term is calcium hydroxide apatite, and this is the brand that we are using. For percutaneous injection laryngoplasty that is done under local anesthesia, normally we introduce or we approach the needle percutaneously. So it can be done either transthyroid, transthyroid through the thyroid cartilage, or transcricothyroid. So in our center, we do double band needle. We do the transthyroid approach, and seldom we do the transthyroid because of the problem of calcification of the thyroid cartilage, and because of most of the time the case is successfully injected using the transthyroid. We don't really do the transcricothyroid. The transcricothyroid is mainly for injection using laryngeal EMG, like Botox injection. So in transthyroid, it is recommended for you to use this technique, which is introduced by Aka et al., double bend needle. The double bend needle, the needle is bent at two sides at the hub of the needle and at 1 centimeter from the tip of the needle, in which in each turn, you bend it about 45 degrees. Okay, so that it is easy for you to penetrate the petiole. Once the petiole is penetrated, the second band would make your life easy to maneuver the needle whether you want to inject anterior or posterior. So not to go dwell more about this, we have done research and we have some modification with the angulation, which is not covered in this lecture. So in this technique of injection laryngoplasty under local anesthesia, you need to give intratracheal anesthesia.
Over the superior thyroid notch. Okay, like so. Withdraw and then inject about 1 cc to the skin. Okay, and then after that, bevel up the needle. Aim below the cricoid cartilage. First trachea ring. You feel the gift. Okay, confirm that you are in the airway. Pandai batuk Okay, batuk. 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 Okay, continue.
Okay, that is intratracheal anesthesia. So this is something that very useful. So when you give intratracheal anesthesia, the upper airway is anesthetized, okay, and you can do whatever you want. So next is bending the needle.
Bend at the heart, 45 degree, and then 1 to 1.5 centimeter from the tip, another 45 degree. Okay, so in the end.
Okay, so then check the anesthesia. When if you touch with the tip of your laryngoscope, patient can't feel it, patient does not gag.
Show me the
It shows that the anesthesia worked.
Okay. Oh, escape Fana. Okay, that's the needle. Going to aim there. Supraglottis, yeah.
Okay, I'm going to show you after this. So this is the needle that entered the epiglottis. Okay, that is the paralyzed side. So after that, you have to allow the second band of the needle to show. Then only you can maneuver the needle and aim where you want to inject. And you over inject about 10 to 20%. Right. So that is percutaneous injection laryngoplasty, transthyroid approach. Another technique is under general anesthesia, transoral injection laryngoplasty. So in transoral injection laryngoplasty, it is ideal if there is no tube in the airway. Provide jet ventilation, a tubeless ventilation, so you can easily inject where you want to inject, and there wouldn't be any tube around here that can impede the augmentation of the vocal fold, and the tube wouldn't be pressing on the vocal cord, that hence it may squeeze out the gel. Okay, this is jet ventilation. So you can see that. So that is tubeless ventilation. So there is no tube, easy for you to inject the vocal fold. So I'm going to show this one. This is not unilateral vocal fold paralysis. What I want to show is just where do you inject. This is a patient who have a tumor in the paraglottic space. And then I have removed the false cord and the tumor is still there. After that, I remove the tumor. So after we remove the tumor, we can see the paraglottic space nicely. All right. Vocal ligament. Next to vocal ligament is thyroarytenoid muscle. At the back here, posteriorly, is the lateral cricoarytenoid muscle. Here you can see whitish thing, that is the lamina of the thyroid cartilage. Then, so you put your needle here, and the gel will occupy this space and augment and medialize the paralyzed vocal fold. So this is the injection. So another thing that you need to know when you inject under general anesthesia is the needle that you use. I use this butterfly needle, but the butterfly needle has to be the one that you can lower lock with the syringe, okay? Because if you cannot lower lock with the syringe, whenever you inject, the gel will seep through here at the connection between the needle, the tube of the needle and the syringe. Okay, this is the video. I'm not going to finish playing this video. You can watch this video on my YouTube channel. And this is a transoral injection, and the patient is given tubeless ventilation. That's a needle. Okay, the paralyzed side is on the left side of the vocal fold. Okay, look at this is the vocal ligament, vocal process, and you go next to it. Okay, and then you wait for the augmentation. A good augmentation, the vocal fold wouldn't balloon up immediately. It should be slowly from inferior, and slowly it fill up the ventricle. Okay, can you see that slowly the inferior part of the vocal fold bulge like that, and slowly it will fill up the ventricle. So in the end, you will get like this. Yeah, continue injection until you achieve 10 to 20%. And after that, the patient, while waking up the patient will be intubated with laryngeal mask. It wouldn't go through the vocal fold. It will be sitting at the supraglottic structure. However, if you do not have anesthetists that can support you with jet ventilation, you still can inject by intubating the patient with MLT, microlaryngeal tube size 5. There will be still space over here, and you inject the same principle. The only drawback is when the patient is extubated, the balloon, although deflated, when they pass through the glottis, it would squeeze some gel from the vocal fold. Okay, so I'm going to show a case demonstration. A patient who was referred 3 months after post-total thyroidectomy. Okay, and intraoperatively, the surgeon said that the nerve is identified and preserved. Okay, but post-operatively, the patient has hoarseness, breathy voice, vocal fatigue, and occasional aspiration. Right, this is the assessment. When the patient come to us, the VHI time 10 is high, the quality of life is affected, 30/40. The maximum phonation time is very short, 3 seconds. The patient has breathy voice. Okay, and this is the laryngeal EMG findings that showed poor prognosis, even though the surgeon said that the nerve is identified and preserved. And this is the voice of the patient.
Semasa saya masih kecil, saya tinggal di kampung bersama nenek.
Voice is breathy, yeah, and this is the scope findings. You can see large glottic gap, okay, and the mucosal waves are asymmetrical. So the patient is offered injection. This is a montage of a glottal cycle. Hope you still remember. I mentioned this in my previous lecture. There is no closure of glottis, okay, and it is always open. That's why the patient has breathy voice and aspiration. And the patient is injected with hyaluronic acid. The patient scared to have the injection under local anesthesia, hence she chose injection under general anesthesia. And this is her voice 2 weeks of the injection.
Masa saya masih kecil, saya tinggal di kampung bersama nenek. Ayah dan mak tinggal di bandar.
You can hear the projection of the voice. Yeah.
Lagi.
And there's now closure of glottal gap, and on montage of glottal cycle, you can see there's closure of glottis, and the duration of closure is half open, half closed, no more, always open. I give you another example that a patient 3 months after total thyroidectomy. Another patient, okay, had excision of acoustic neuroma, not translab. This is done by neurosurgeon through the posterior fossa approach. Immediately post-op, the patient has breathy voice and aspiration of fluid, and there is penetration of fluid can be seen beyond the glottis, and speech language pathology suggested nasogastric feeding. Okay, and this is the video of the patient. The severe bowing, the vocal cord in lateral position, and there's gap, and there's some squeezing of the upper part of the glottis, the false cord, right? And this patient had undergone, we did transthyrohyoid under local anesthesia, injection laryngoplasty using a double band needle. Okay, you can see the needle here at the paraglottic space, inject until there is overcorrection about 10 to 20%. And the patient immediately, we wait until the local anesthesia wean off, about 2 hours.
Okay, so slow macam tadi. Kita tengok lirik, gambar lirik, ulang lagi. So, bila kita inject tu,
Okay, the patient can drink without aspiration, and thus he doesn't have to go home with nasogastric feeding. And this is 3 weeks post-injection. You can see closure of glottal gap at 6 months post-injection. This is his voice.
Semasa saya kecil, saya tinggal di kampung bersama nenek. Ayah dan emak tinggal di bandar.
And this is the stroboscope findings. You can see at 6 months, there is less squeezing of the false cord, there's closure of phonatory gap, although the vocal folds still paralyzed, of the right vocal fold still paralyzed. Okay, now we have finished about injection laryngoplasty. So I hope you understand early intervention. You can do as early as possible, immediately post-operation, and you can also do intraoperatively. Okay, for example, during thyroid surgery, you can do it on table, transoral under general anesthesia. Now, I'm going to talk about laryngeal re-innervation, another surgical option for unilateral vocal fold paralysis. I learned this surgery from Professor Martin Anthony Birchall, University College London. This is my photo during graduation of PhD in 2015. And this is these are my children, 3 children. Eldest one back in 2015, my husband, my youngest one. Is to show you the picture, a picture in 2022, recently June. So my children graduate, my youngest one now already 15-year-old. Right, so what is the function? What is the principle of laryngeal re-innervation? The aim, the principle is to restore laryngeal function by regenerating new motor axons from a donor nerve to re-innervate the paralyzed vocal fold or paralyzed muscle. And the new motor axons will grow and re-innervate the intrinsic laryngeal muscle, right? So for laryngeal re-innervation, okay, this is a diagram showing a different techniques of doing nerve repair in general. What re-innervation nerve repair is not only for recurrent nerve, other nerves also you can do nerve repair. So number 1 is technique of neurography, where you do end-to-end repair. Okay, another one when there is a big gap and you cannot approximate the nerve, okay? So you have to put a cable graph, okay, to do the repair, okay? And this cable graph will channel axons from here to the distal part. Another type is by implanting the nerve on the muscle that is need to be reinnervated. So either the nerve is directly implanted on the muscle, or the nerve together with island of muscle, of donor muscle, of donor nerve, and implanted on the paralyzed muscle. And some surgeons use a conduit to make sure that the nerve is the sprout of the nerve is focused to the denervated muscle. Okay, and this is another one. You can also use conduit to enhance the growth of the nerve. So the laryngeal reinnervation, there are mainly two types. For unilateral vocal fold paralysis, non-selective reinnervation is recommended, because in unilateral vocal fold paralysis, the problem is phonatory gap during phonation. Okay, I've shown this video many times already. So there is phonatory gap, airway not a problem, voice the issue, and aspiration. So hence, in this surgery, a donor nerve is used to be repaired, to be sutured to the injured recurrent laryngeal nerve. So there will be regeneration of new axons, and slowly the regenerated axon will travel through the distal part of recurrent laryngeal nerve and reinnervate the intrinsic laryngeal muscles. Remember, the recurrent laryngeal nerve consists of abductor and adductor axon. So if this surgery is successful, the reinnervation will occur on all muscles, intrinsic muscles, except the cricothyroid muscle. Then, so I'm showing this photo from this paper by Wong et al. The first part shows before reinnervation. The left vocal fold is bowed in lateral position. The arytenoid is anteromedially prolapsed, and phonation, there is big phonatory gap. And after reinnervation, there is no more bowing. The position from lateral become paramedian. The arytenoid is placed beautifully on the cricoid, and during phonation, there is closure of phonatory gap. So therefore, this is the aim, not to get mobility, but to get tone and bulk, good position, so there would be closure of phonatory gap during speaking as well as during swallowing. However, for bilateral vocal fold paralysis, if you do reinnervation, you should do a selective type, where the reinnervation is targeted to the muscles, especially muscle that responsible for abduction, because in bilateral vocal fold paralysis, the problem is airway. So you can see in this video, the voice is good, but during breathing, the vocal folds wouldn't abduct. Hence, there is small airway and the patient has stridor. So the reinnervation should be targeted in reinnervating the PCA. You have to avoid the occurrence of synkinesis, because if synkinesis occur, there wouldn't be any mobility. So that is what we call selective reinnervation. So in selective reinnervation, phrenic nerve is used to reinnervate, target the reinnervation to PCA, so that phrenic nerve is also innervate the diaphragm. So whenever there's diaphragm movement for respiration, it will stimulate and contract the PCA for opening of the glottis. And to maintain voice, separately, ansa cervicalis is used to reinnervate the adductor muscles. So this is what we call selective reinnervation. This surgery in good hands take about 8 hours, and tracheostomy is mandatory while waiting for the recovery of function. So we're going to focus on non-selective reinnervation. The topic today is unilateral vocal fold paralysis. So I have shown the diagram generally how the repair can be done. And now what nerves can be used and what technique can be used specifically for the laryngeal reinnervation. The common one is using ansa cervicalis and repair it to recurrent laryngeal nerve. This is introduced by Crumley. And the other common one is direct end-to-end repair when the proximal and distal part of the recurrent laryngeal nerve can be identified, and you can do non-tension anastomosis. These are other surgical techniques like the nerve muscle pedicle. You remember the implant, the nerve is implanted directly to the muscle. Implantation that modified by Tuckers, and there are surgeons published the use of hypoglossal nerve, but not many people like to use hypoglossal nerve because you are kind of robbing one person and donate to another person, because the tongue function will be affected for chewing, swallowing purposes and speech purposes. So these are the two that common ones recommended for unilateral propofol paralysis. So just to touch a bit on ansa cervicalis, you need to know the landmark, how to identify the ansa. The most important one is the omohyoid. So you can find the ansa overlying the IJV near the omohyoid, either just there near the omohyoid, or sometimes it can be inferior to the omohyoid. So either you use the main branch of the ansa cervicalis over here, or you can use the nerve that supply the sternothyroid muscle or the sternohyoid muscle. That also recommended. And you need to identify the recurrent laryngeal nerve. If you do reinnervation delayed, okay, like 3 months, 6 months after thyroidectomy, it is difficult for you to find recurrent laryngeal nerve over here. So alternatively, you can open up the superior constrictor muscle, the thyropharyngeus muscle over here, and identify the nerve intralaryngally. Okay, and when you have identified both nerves, the nerve that entering the larynx and the ansa cervicalis, either the sternohyoid or sternothyroid branch, you need these instruments to do the repair. Okay, this is, I'm not going to play the video. I just want to, maybe you can go to my YouTube channel and you can watch the video how we do delayed non-selective laryngeal reinnervation, not on table. Okay, delayed. We open up the neck after 1 year of thyroidectomy. And I'm going to show here a video on repair. One surgical technique that you have to remember, which enhance the success of surgery, is the repair has to be done epineurium to epineurium. The needle shouldn't step through the fascicles of the nerve. Okay, epineurium to epineurium. Okay, I don't have to finish the video. Okay, and this is a picture showing the delayed non-selective reinnervation. That is superior part, inferior part, lateral border of the thyroid cartilage. This is lateral part, the superior constrictor muscle, the thyropharyngeal muscle already retracted laterally, piriform fossa already protected, and you find the nerve over there, right? And the ansa cervicalis is brought medially and repair is done. This picture shows on table primary non-selective, a patient who had undergone thyroidectomy, the strap muscle is normal there, and the nerve is injured. So we have preserved the ansa cervicalis. So the ansa cervicalis swung medially, okay, and repaired to the recurrent laryngeal nerve, right? And after that, the repair is enhanced with tissue glue. Like that, human tissue glue. And after the surgery have finished, the neck is closed, the patient is injected with hyaluronic acid. So just now, in the initial part, the injection laryngoplasty is standalone. When you are waiting for the function to return, when you suspect neuropraxia or you don't know the status of the nerve. But this injection laryngoplasty is done together with reinnervation. Why it is necessary? Because the effect of re-innervation wouldn't occur overnight. The nerve regeneration take about 1 millimeter a day. So the effect will take about 4 to 6 months. So remember, generally the effect of injected is about 4 to 6 months. So hence, by the time the injection laryngo, the gel start resorbing, the re-innervation will kick in and the patient will get better and better voice. So here I'm going to show some case demonstration. Okay, this is a patient where we did a delayed re-innervation, and the etiology of unilateral vocal fold paralysis was all pulmonary tuberculosis, fibrosis on the upper lobe of the lung, pulling the recurrent laryngeal nerve. The patient has permanent recurrent laryngeal nerve paralysis, and this is the when the patient come to our clinic. Okay. You can see that during phonation, the vocal fold cannot be seen at all because of severe muscle tension dysphonia, the squeezing of the upper part, and the patient feel her voice is, to produce voice, she needs a lot of effort and she has vocal fatigue as well. We have done non-selective re-innervation with injection laryngoplasty, and this is her larynx 12 months post laryngeal re-innervation. Why I am showing you here, I want you to appreciate that in non-selective re-innervation, there is no return of mobility, but there will be return of tonal bulk, good position, and good arytenoid position. And you would see that at 12 months post re-innervation, you can see the vocal fold during phonation, and there is no marked muscle tension dysphonia. Okay, you can see the vocal fold, unlike at presentation. And this is a patient at 2 years after re-innervation.
Masih kecil, saya tinggal di kampung bersama nenek. Ayah dan emak tinggal di bandar. Abang dan adik saya tinggal di bandar bersama ayah dan emak.
This is her voice. Very good. And this is the larynx. There is no muscle tension dysphonia, and she has good closure and symmetrical mucosal wave. And this is the montage of a glottal cycle. Good closure, complete closure with duration of closure of half open and half closed. That is delayed re-innervation of etiology of pulmonary tuberculosis. Another one we did, I want to demonstrate here, you can do the re-innervation on table when the nerve is accidentally transected. This is the best time if you can do it. And this is the voice of the patient 2 weeks post-operation. Total thyroidectomy, non-selective re-innervation on table, and injection laryngoplasty.
Okay, boleh mula. Semasa saya masih kecil, saya tinggal di kampung bersama nenek. Ayah dan emak tinggal di bandar. Abang dan adik saya tinggal di bandar.
The voice is not perfect, but it's not breathy, severely breathy. She has some strained component of a voice and some roughness. This is her larynx at 2 weeks post-operation. You can see there's hyperadduction of the ipsilateral false cord to try to help, but there is closure with small phonatory gap. This is her voice 1 month after surgery.
Semasa saya masih kecil, saya tinggal di kampung bersama nenek. Ayah dan emak tinggal
Her
di
voice is
bandar.
better, there's more straining and the roughness has reduced. And this is her voice 12 months after surgery.
Masih kecil, saya tinggal di kampung bersama nenek. Ayah dan emak tinggal di bandar. Abang dan adik saya tinggal di bandar
Her
bersama.
voice continued to improve. Now
Masih
I'm
kecil.
going to show you the larynx. Please remember the 1 week, the 2 weeks post-operation and 12 months after surgery. Hope you can appreciate that she doesn't use the false cord that much to help. There's closure of phonatory gap, symmetrical mucosal wave, and good position of the arytenoid. And this is duration of closure is permanently closed. Sorry, predominantly closed. And publish this paper, you can read up on primary non-selective re-innervation in acute paralysis on table And in this paper, I have demonstrate, the natural cause of recovery of voice outcomes after the surgery from baseline 1 month, 3 months, 6 months, and 12 months. Can read up the paper. Okay, so in large glottic gap, you still can do a delayed 1 year post-thyroidectomy, a patient with large glottic gap. Yep, can you see large glottic gap? And the voice of the patient was really breathy.
Sama ayah dan mak. Setiap minggu saya dan nenek pergi ke
very breathy. I'm not going to show one by one, but I want to show you at 12 months, at 6 months post renovation.
Semasa saya kecil, saya tinggal di kampung bersama nenek. Ayah dan mak tinggal di bandar.
Okay, so the voice is a lot better. Okay, with good projection and there's no breathiness component. And this is good closure of phonatory gap with duration of closure half open, half closed on stroboscopic examination. So that is about laryngeal reinnervation. There's using a donor nerve, injection laryngoplasty to help while waiting for reinnervation to kick in, and time that you can do reinnervation can be on table as soon as possible if the nerve is cut, or you can do delayed up to 3 years after palsy, okay, and make sure that the donor nerve is present. Another type of surgery that you can perform on unilateral vocal fold paralysis is type 1 thyroplasty. Okay, there is type 1, 2, 3, and 4. The type 1 is for medialization of the vocal fold. It is a laryngeal framework surgery in which window is created at the thyroid lamina at the level of the vocal fold, and implant is inserted to medialize. So if in reinnervation, the tone and bulk occur because of reinnervation, okay, but this one, the good position of the vocal fold is achieved by pushing it with an implant. So implant can be used that been published in the literature like Gotex, EPTFE, okay, there's a long name for it, celastic block, which surgeon have to carve the celastic block before inserting into the paraglottic space. Montgomery, a pre-made celastic block, you don't have to carve, it's already pre-made with different sizes and different sets of male and female, and the most expensive one is titanium implant. So in doing type 1 thyroplasty, identifying the level of the vocal fold is the key of success. Okay, so in type 1 thyroplasty, when you have exposed the thyroid cartilage, you need to identify the inferior tubercle and the superior thyroid notch, the inferior thyroid notch, and then from here, you draw an imaginary line that is midpoint between the superior and inferior thyroid notch and above the thyroid tubercle. So the vocal fold lies just here beneath the equator or the midline, okay, imagining that you have created. So the window is created at the level vocal fold over here, below the imaginary line and above the inferior tubercle, inferior thyroid tubercle. So the long name of the Gotex is EPTFE, expanded polytetrafluoroethylene. Okay, it is invented in 1969. Okay, this is a surgery for Gotex thyroplasty. For reinnervation, the surgery is done under general anesthesia. For Gotex type 1 thyroplasty, the surgery is recommended to be done under local anesthesia because you need to fine-tune the voice. When you insert the implant, you get cooperation from the patient to phonate for you to determine how much medialization that you want to achieve. All right. So cutting the skin, go to the midline, retract the strap muscle, and then expose the thyroid cartilage. Identify the inferior tubercle, the horizontal, the imaginary line, a drill, create a window using a drill and insert the Gotex and test the patient, adjust the implant according to the patient's voice, anteriorly, inferiorly, and posteriorly. Insert the Gore-Tex. So in type 1 thyroplasty, if the surgery is successful, the voice improvement is immediate. This is the best example of a patient. Of course, not all the time the surgery is perfect. Okay.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
That is before surgery. The patient's voice is breathy and the patient cannot finish 1 to 10 in a single breath. And this is immediately after surgery. You can see there's plaster over there. Okay.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Okay. So that is immediate. Okay. We have published our results in 7 years experience. You can read this paper published in Malaysian Journal, Malaysian Medical Journal, MJM. And there is a paper documenting the complications of Gore-Tex thyroplasty. So remember that in type 1 thyroplasty and in Gore-Tex thyroplasty, the complication rate is about 11%. So what are the complications that may occur? The implant that we insert may migrate superiorly, inferiorly, or may extrude internally into the airway. And another complication that has been described is other than migration and extrusion is over-medialization of the implant. So although if you do over-medialization, although the vocal fold is medialized, but the voice is not perfect because over-medialization will cause stiffness of the vocal fold. Hence, the vibration of the vocal fold will be affected. So now, I have talked about these two techniques, non-selective reinnervation and type 1 thyroplasty. These are the two options for permanent intervention in non-recovered function of recurrent angina paralysis. Okay, generally, non-selective reinnervation is done under general anesthesia. For type 1 thyroplasty is local anesthesia. The surgery is longer in reinnervation because you need to find the nerves and then you need to repair the nerve. In type 1 thyroplasty, it is shorter, about 1 to 2 hours. The longest part is to fine-tune the voice. In reinnervation, you need to identify these two nerves I have mentioned. In type 1 thyroplasty, it is crucial for you to identify the correct level of the vocal fold. Fine-tuning is unnecessary in non-selective, but in type 1 ischemic thyroplasty, fine-tuning is pertinent, is crucial. And the adjunct procedure for reinnervation is injection laryngoplasty, whereas for type 1 thyroplasty, the adjunct procedure is arytenoid adduction, especially if the arytenoid is prolapsed in anteromedially. So we have published our results comparing non-selective reinnervation and type 1 thyroplasty, and we have shown that between the two, both improve patient's voice. However, in non-selective reinnervation, at least in our center, okay, after we select our patient properly, okay, according this inclusion and exclusion criteria, the voice handicap index is significantly better in non-selective reinnervation compared to thyroplasty, and the maximum phonation time is significantly longer compared to type 1 thyroplasty. So in conclusion, okay, in unilateral vocal fold paralysis, surgical intervention is not like before. Before those days, surgical intervention is offered after 6 months, and within that 6 months, watch and wait. But now, the paradigm shift on treatment, surgical intervention is offered as soon as on table, as soon as within 6 months. And after 6 months, there are other surgical options that you can offer. For reinnervation, it is more special because you can offer it either on table within 6 months or chronic. Okay, so it is more robust. All right, and so this is the conclusion. Injured recurrent angina nerve has propensity of spontaneous regeneration. okay, but normally suboptimal. You still have to do some intervention to help the patient's voice. And spontaneous reinnervation commonly occurred with synkinesis, especially if it's type 3, 4, 5, according to Sunderland classification. Remember about abductor and adductor axons within one nerve. Okay, that is the reason why synkinesis is common in recurrent laryngeal nerve. Right? Non-selective reinnervation is an option for acute, subacute, or chronic phase. Okay, successful surgery will result in reinnervation of paralyzed laryngeal muscle. With synkinesis, there's no mobility, but with a good tone, good bulk, and favorable position of the vocal fold. And in a reinnervation, non-selective, all muscles, the TA, LCA, interarytenoid muscle, and PCA will be reinnervated. So hence, other than good position, good tone, in successful surgery, the arytenoid position also will be repositioned. I mean, the arytenoid position will be good, okay, without having to do arytenoid adduction or arytenoid plexy. Okay, so that is the end of the lecture. Thank you for your kind attention. I welcome any questions, from you.
Thank you, Prof. Marina. Before the question from the audience, I want to ask you about the injection with the permanent material that you mentioned before. Do you have any experience using that? Because we usually use the injection laryngoplasty, but we never used the permanent material before.
Okay. So far, there is no permanent material. What we have is short-term and long-term. Okay. Yeah. For example, the one that I've shown in the lecture, calcium hydroxyapatite, the texture of the gel, whenever it is crystallized, it is harder compared to hyaluronic acid. Hence, it lasts longer, but it do resolve with time. So it can last up to 1 year or probably more than 1 year. Okay, but then it is the chance of the patient need to repeat the injection after 1 year still there. It is not permanent. Okay, it is considered long term. So I don't offer KAHA if I suspect that the patient has neuropraxia. I suspect that the patient may the function will recover. Okay, so KAHA normally I offer for patients who are not suitable for reinnervation, refuse type 1 thyroplasty. So I offer injection with long term. And I tell the patient there's chance that you may need to repeat this after 1 year. Okay, why I do not like to offer in temporary type? Because number one, the duration. Number two, KAHA normally the consistency is harder and it causes more inflammation compared to hyaluronic acid. So another group of patients that is suitable for KAHA is those patients who have poor prognosis in terms of cancer. For example, patient have lung cancer. With unilateral vocal fold paralysis, patient have to undergo chemotherapy and so on. There's a lot of things the patient have to go through. So offering injection laryngoplasty with KAHA is the best for the patient, rather than the patient have to undergo surgery and another incision, and the patient may not be able to stand, lying down for so long. So for those kind of patients, we offer KAHA.
Okay, thank you, Prof.
Yeah.
Maybe we go to the audience question from Ridwan. Maybe that's your resident, Prof. Salam, Prof. When you innervate ansa cervicalis and apply the human glue, wouldn't it stick around the adjacent tissue, and will it cause adhesion to the other structure vessels, nerve, etc.? How does the glue helps? Thank you, Prof.
Okay.
From Ridwan.
Thank you for the question, Ridwan. The glue wouldn't cause harm to the surrounding structure because it's human tissue glue. Okay, so it will resorb with time. it is enhancing the suture that we have made. For the suture, we don't do like many sutures. You only do 3 knots on the nerve, right? So we enhance the repair with glue so that it wouldn't move around, right? And with time, it will resolve. Okay, it wouldn't cause any harm to the surrounding tissue. Okay, that's my answer.
Thank you, Prof. How about the cicatrix or the fibrosis and the nerve, Prof? It could we happen, or we can be prevented with using a steroid or something like that?
Fibrosis of the nerve. Okay, if you handle the nerve carefully, and if you repair the nerve according to the recommended technique, like, you don't touch the fascicles, you just touch the outside of the nerve. Yeah, you need a micro instruments and microscope so that the way you handle the nerve is not crude way, very gentle, and you just touch the epineurium, and the needle also go through the epineurium. The fibrosis wouldn't be an issue. Okay, so yeah, probably fibrosis may settle if you may occur at the repair side if you handle the nerve roughly. Okay, so you have to be gentle in handling the nerve. So I don't give steroid to this patient because steroid may also affect the healing, right, of the site of repair. So I don't normally give steroid, and I don't know whether giving steroid will reduce the chance of fibrosis at the site of repair. So I cannot answer that question, because that is not my routine practice in giving steroid post reinnervation.
Okay, thank you, Prof. Maybe for other question from Ratna Widyaningrum. She asks 3 questions. The first question, Assalamualaikum, Prof. The first question is is there any difference result of transcutaneous and transoral injection laryngoplasty? Which one is better and the best material for injection based on your experience? The second question is, how is the post-operative evaluation of the patient? Is there any possibility for recurrent paralysis? Then the third question is, what is the indication for choosing between injection laryngoplasty and surgery? Thank you, Prof. Maybe you can answer
Thank you for the question. Okay, thank you. Good question. So any difference between transcutaneous and transoral? Okay, with generally both give similar results. Okay, but I can't.
Maybe mute, Prof. You.
Okay, all right. So for between transoral and percutaneous, generally when we see patient in the clinic, the voice outcomes are similar. Okay, but in transoral injection using the butterfly needle, okay, the use of the gel may not be optimized because there is tubing. There is some about 0.3, 0.4 cc of gel lost in the tubing. Okay, so that may affect the voice, but generally post-operatively patients happy with the voice. We are yet to come with a statistical analysis about the difference of voice outcome. My postgraduate student is doing research on that now, collecting all those cases and comparing between the voice outcome between the GA and local percutaneous. Generally, from our assessment in the clinic, it is about the same. Okay, how do you select between GA and percutaneous? Is you see the patient. If the patient is anxious, don't do under local anesthesia, because the patient may not be able to tolerate. Patient may develop vasovagal. By the time you want to inject, the patient feel giddy. Okay, the patient may develop laryngospasm. Okay, or if the patient have thick neck, edematous neck, you cannot identify the laryngeal framework where you want to inject. That is another candidate you have to do general anesthesia. Okay, and one more thing is, if you perform this injection together on table at the same sitting in acute paralysis, so there is no option, you have to do transoral general anesthesia. So there are pros and cons of doing percutaneous and transoral, but generally the voice outcome is similar. Whether there is statistically significant difference or not, I'm going to let you know when our study finish. Okay, how is post-operative recurrence of paralysis? Okay, it depends whether the injury to the recurrent laryngeal nerve is neuropraxia or a transection. Okay, if it is just edema due to traction, okay, neuropraxia type 1, okay, or maybe type 2, Sunderland classification, the nerve function may return, after like 2 months, 3 months after injection. Okay, but then some patients who we inject, we're not sure the status of the nerve, and we inject while follow up 4 months, 6 months, the nerve function wouldn't recur. Okay, it is a permanent paralysis. If there is no reinnervation, spontaneous reinnervation occur, the voice will become more and more and more breathy. Okay, hence, then that time you have to offer permanent surgical treatment. But there are some patients, you inject, the voice is good, you follow up to 6 months, the voice remain good, but the nerve mobility, the vocal fold mobility still the same, still immobile. This is because the reinnervation, spontaneous reinnervation has occurred with synkinesis, but good position, because you give the position is already determined by the early injection that you have given. I hope that answered the question. So whether or not there's recurrence of paralysis, or whether the paralysis remain or not, depends on the status of the nerve, okay, when the nerve is injured. I hope that answered the question. And the third question, what the indication of choosing between injection laryngoplasty and laryngeal reinnervation? Okay, injection laryngoplasty normally is offered for temporary, okay, during the watch and wait period. Remember I said those days when patient come with unilateral vocal fold paralysis, what do? You offer the patient, you send the patient to speech therapist. Okay, for voice therapy, if the patient has aspiration, you insert RAS tube and the patient have to wait for recovery of the nerve, okay, before the patient can take orally. Okay, but now you can, instead of sending the patient for speech therapy during the watch and wait, okay, period, while waiting for the nerve to recover, maybe this is neuropraxia, you give injection with temporary material like hyaluronic acid. So within that 6 months, if the nerve recover, the voice will become better and better. Okay, but for reinnervation and thyroplasty, you offer this intervention when you are sure that there is no recovery of function, when you're sure that the nerve injury is permanent. Okay, and in reinnervation, it is done together with injection, because the injection help the patient voice while waiting for the reinnervation to kick in, because the nerve grow take about 1 millimeter a day. Okay, it takes about 4 to 6 months. I hope that answered the question. Okay, any other question?
Okay, Prof. Maybe from Sarah Lee. After reinnervation, how and when would you assess recovery or regeneration, Prof?
Okay, so after reinnervation, one way of assessing good reinnervation is after 6 months, the voice of the patient continue to be good and become stronger and stronger. Okay, because if there is no reinnervation and the voice of the patient just rely on the hyaluronic acid that we have injected, after 6 months, the gel will resorb. Okay, and if there is no return of bulk, no return of, if there's no bulk and tone, okay, the voice become worse and worse. Okay, that is one way to know whether or not the re-innovation is successful. Another way of knowing the re-innovation is successful or not is by doing laryngeal EMG, where the laryngeal EMG can demonstrate how much recruitment of motor unit action potential is generated during phonation, okay, during the laryngeal EMG. So you can be confirmed electrophysiologically by doing laryngeal EMG. I hope that answered the question.
Thank you, Prof. Maybe another question from Dinur from Jakarta. I would like to ask if there is any complication from the re-innervation procedure, and is there any procedure to anticipate if the re-innervation failed after a few months of evaluation?
Okay, very good question. So complications, not many. I have encountered a complication whereby during identifying the nerve intralaryngally by cutting the superior constrictor muscle, the thyropharyngeal muscle, we accidentally cut the pharynx, okay, and we have to repair the pharynx. All right, that's only one case. And retrospectively, when I looked at the CT scan, why it occurred? Because patient has a variant of pharynx, whereby the pharynx, instead of hiding under the thyroid cartilage, it goes lateral and on the lateral border of the thyroid cartilage. That's the reason why when we cut the muscle, the pharynx is cut as well. But that's the only complication of cut of pharynx. Another complication is neck infection that occurred in one patient when I did my PhD in London. And the voice outcome was not so good because there's infection and the patient had neck abscess. Okay, so and hence since then I give antibiotic routinely for patients who are undergoing this procedure. Another complication that had occurred, that also in the UK, the patient developed severe odynophagia after surgery, and the patient has to be on rice soup for 2 weeks, and after that, the patient was well. I think that's the three types of complication that has occurred in a non-selective laryngeal re-innovation.
Thank you.
And if re-innovation is failed, okay, you wait after 6 months for you to decide whether or not you want to offer other surgical intervention. What you can offer is type 1 thyroplasty. You still can offer type 1 thyroplasty. It can go vice versa. Jean-Paul Marie have published a paper where he did laryngeal re-innovation as a salvage surgery in patients who failed type 1 thyroplasty, and the re-innovation works. So vice versa, if you do re-innovation first and it fails, you can do type 1 thyroplasty, but you don't wait 1 to 2 months for you to decide. Remember, it takes about 4 to 6 months for the nerve for the nerve to kick in. Okay, so you wait after 6 months. After 6 months, if the voice becomes breathy, there's no signs of good tone and bulk and position, then you can offer the patient type 1 thyroplasty. So far, we have not come into that yet. Yeah, I mean, none of our patients who had undergone non-selective re-innovation have to undergo type 1 thyroplasty. However, there is one patient, this patient has multifactorial issues. When I did the non-selective re-innovation following total thyroidectomy on table, before the total thyroidectomy, the patient already had pre-existing vocal cord palsy, unilateral. And when he came for the total thyroidectomy, there was no voice at all. The patient was practically like whispering. There's no voice at all and has aspiration. So total thyroidectomy is performed. He has papillary thyroid carcinoma, and the patient also at that time already have lung metastasis, right? So I did non-selective re-innovation and injection laryngoplasty. And the patient post-operatively regained the voice, happy with the voice, but with time, 4 months, 6 months, after 6 months, the voice, instead of become stronger and stronger, yeah, after like 8 months after re-innovation, the voice become less stronger, but not like before the surgery, not like whisper, but then become more fatigue, and the lungs condition become worse. Okay, you know, like voice production is also contributed by lung function. Okay, if you have bad lung function, your voice will also be affected, yeah, the stamina of the voice. And this patient does not want thyroplasty, so I injected the patient with KAHA, and the patient is doing well. Okay, that is a kind of fail re-innovation, but it's not 100% fail. Okay, so conclusion is you can offer long-term injection laryngoplasty or type 1 thyroplasty if the re-innovation fail, but you have to wait after 6 months for you to decide on that. While waiting for the 6 months, for example, if the hyaluronic acid resolve too quick, you can re-inject with HA, yeah, while waiting for the 6 months. Okay, next question.
Maybe this is continuous question from the the question before from Donna Kong. If failed re-innervation, will you re-innervate using opposite side, or you will revise using other answer branches?
Okay, thank you. Well, thank you, Ezzy from Marina Beautiful Cases. Thank you. You are following my lecture. Thanks. Donna, thank you for the question. The question is whether I would use the opposite side. In the literature, some surgeons publish the results on using the opposite side. In my hand, I've never used or tried using the opposite side because I don't like using a cable graft. If you use opposite side, when you want to bring the ansa cervicalis to opposite side, okay, you may have to use cable graft. So I don't know. In my hand, I cannot tell you what is the result, but to answer that question, yes, it is possible. It has been done by other surgeons, and the main surgeons that have done re-innovation using the opposite side is group of in China, a group of researchers and surgeons in China. They have published a paper using the opposite side. Let's say the ipsilateral side, the ansa cervicalis is not there anymore. Yeah. Especially the patient have undergone neck dissection and the head and neck surgeon did not preserve the ansa cervicalis, so you still can use the opposite side.
Okay, thank you, Prof.
Okay.
Maybe the next question. This is an interesting question. I never developed the vasovagal in my experience, but the question is very interesting. If the patient develop a vasovagal or laryngospasm during injection laryngoplasty in the clinic, what do we do?
Okay, right. So I have experienced this case before. So I've learned the lesson. So when I'm doing injection under local anesthesia, I make sure that there is oxygen monitor by the side of the patient. Okay, let's say the patient become anxious, doctor, I feel breathless, but there's no stridor. Now I quickly put the pulse oximeter and ask the patient to look at the oxygen saturation to calm the patient down. Say like, oh, you're okay. This is all the feeling of numbness in the throat. You don't feel like the air, but you are breathing well. Look at the oxygen saturation. That's one way to calm the patient down. But if the patient develop vasovagal, I have to stop the procedure, lie the patient down, put the leg up, okay, massage the patient's leg, and then calm the patient down, saying that this is okay, and eventually the patient recovered. Okay, this is like other cases. I'm sure that you have seen vasovagal while you put scope in, the patient suddenly like become white and then feel like fainting. Okay, so you just put the patient, lie down the patient, reassurance, and the patient will recover. For laryngospasm, calm down the patient. I always have oxygen at the side, give nasal prong, okay, and stop the procedure. Okay, I just had one patient with laryngospasm, but the oxygen saturation that went down picked up after like 15 seconds. Okay, so I didn't have to do, by the time I want to give the oxygen already picked up. Okay, so you have to stop the procedure calm the patient down, give oxygen, nasoprong, okay, and keep talking to the patient. Tell the patient to breathe through the nose. Tell the patient there's nothing wrong, there's nothing obstructing, okay, you don't have to worry. Okay, so that patient who developed laryngoplasm, in the end, we don't have to do anything, it recovers.
Thank you, Prof. Maybe the next question from Sanas Kananda. I don't really know what this is. Is there the name? Is that same treatment for recurrent laryngeal nerve paralysis with the paralysis superior laryngeal nerve, Prof? I don't know what the
Okay, thank you for the question. Okay, so recurrent laryngeal nerve, it is mixed sensory and motor nerve. Okay, but for the superior laryngeal nerve, the external branch that is supplying the cricothyroid is motor nerve, and the one that is supplying the sensation is the internal branch of the superior laryngeal nerve. Okay, so treating superior laryngeal nerve is more difficult than the recurrent laryngeal nerve. Okay, so far people have published some case report on using great auricular nerve to re-innervate the sensation of the pharynx up to the above the glottis, which supplied by the internal branch of the superior laryngeal nerve. And for the external branch, people have used cricothyroid to cricothyroid re-innervation. So the answer to the question is the technique is not the same because it is a different nerve and supplying different muscle. Okay, so you have to use different nerve. For the internal branch, you have to get another sensory nerve, which is great auricular nerve. Okay, then I don't know whether it's easy or not to find the internal branch. Okay, and for the cricothyroid, okay, you can take a cable graph, innervate the implant it on the cricothyroid muscle. Yeah, cricothyroid muscle is the most superficial. You can expose it anterior to the cricoid lamina. You put a graft between the two muscles. So the principle is the good muscle, the one that have good nerve, good innervation, will borrow or there will be sprouting of axons from the normal muscle to the opposite muscle of the cricothyroid. Okay, so I have observed this operation once. There is some improvement. This patient is professional singer. What do you call that? Tamil classic singer, something like that. Yeah, when I was in the UK. So there is some improvement, but to get the high pitch is still difficult. Still difficult. Yeah. So two techniques: cricothyroid to cricothyroid re-innervation using a cable graph, and for the internal branch of the superior laryngeal nerve for the sensation, you have to use great auricular nerve. And the technique is not like the recurrent laryngeal nerve; it's different.
Thank you, Prof. Maybe another question from Jemima Ling. If the patient operated neck dissection elsewhere and unsure of the status of ANSA, is it possible for re-innervation? Which nerve will you take if no ANSA identified during re-innervation?
Okay, very good question. If the patient had undergone neck dissection in other center and the status of ANSA is unknown and the surgeon also can't remember whether you can call the surgeon and ask, if unknown, then I wouldn't offer re-innervation because there's no donor nerve. There's no donor nerve, I wouldn't do re-innervation. I would straight away offer type 1 thyroplasty if it is already like more than 6 months and show that this is a permanent paralysis. If the patient not keen on surgical incision, then I offer long-term injection, which is the calcium hydroxyapatite.
Okay, thank you, Prof. Maybe next question from Adlan.
Oh yeah, in addition to that, remember that someone asked about the opposite side. The other option, if the answer is not available on the ipsilateral, you can borrow answer from the opposite side. It has been published in the literature by other surgeons, but I personally have not done it.
Okay, thank you, Prof. Maybe another question from Adlan. What is the complication between the two procedure? And should we concern about post-procedure? What two procedure?
What are the two procedures?
What are the two procedure? Maybe Adlan can wrote or ask personally. What the two procedure that you mean in this chat?
Okay, so maybe I can assume that the two procedures, probably the thyroplasty and re-innervation. So the re-innervation I have mentioned just now, neck infection, neck abscess, injury to the pharynx. If you do the technique like I have mentioned in my lecture, cutting the thyropharyngeal muscle and identifying the nerve intralaryngally. Another complication is because you make a cut over there, the patient may develop odynophagia, but those complications, one each that I have encountered. Okay, so other complications for type 1 thyroplasty, the complications being documented in the literature. Number one is airway hematoma, okay, causing airway obstruction, implant extrusion into the airway, migration of implant superiorly or inferiorly, and yeah, that's about it. And over-medialization of the implant. And of course, in type 1 thyroplasty, infection, neck abscess is also possible.
Prof. Marina, can I ask a question?
Hi, Azzy.
Hi, good morning. Nice, very beautiful cases.
Thank you.
I just wonder, we know that sometimes in thyroidectomy, they have like a delay, paralyzed, like after 1 month and then 1 year, and then they get the focal cord is paralyzed. Do you have any experience about this case? And then do you have any suggestions to this case like this?
Okay.
Is it possible that we did the open procedures and then we remove all the fibrotic soft tissue that push the focal cord, what do you call it? Make the recurrent nerve dysfunction. Like we did the operation in a facial nerve, like in a otitis suppurative chronic. Sometimes they remove all the cholesteatum like that. Is it possible we did procedures like that, or do you have experience for that?
To be honest, thank you, Azzy. It's very rare, the case that you said just now. I've never experienced that, and I've never received that kind of referral. And the question whether or not we should open, I also can't answer that because I have no experience. I'm not sure by releasing the adhesion would improve the function or not. I would say that to open up and to find the nerve and to release the adhesion wouldn't be an easy task. Because I have opened up cases post-thyroidectomy before. To open up the tracheoesophageal groove to find nerve over there is almost impossible. And you don't know which one is the nerve. It's everything like adhered to each other. So that's why in post-total thyroidectomy, I go to the virgin site first, the intralaryngeal, then I track the downward to see where is the injury. I think if you want to use the same technique, maybe possible. Identify the nerve intralaryngally at the piriform fossa, and then you trace downward and see where is the site of fibrosis and try to release the fibrosis. Whether that would be successful or not, I'm not sure. probably before doing, if you want to embark on that, before the surgery, you do laryngeal laryngeal electromyography to see the status of the nerve. If let's say there is too much of poor prognosis signs, like the motor unit action potential is very small, and there is a lot of signs of ongoing degeneration, like spontaneous activities, fibrillation potential, maybe not worth doing the release. Maybe if you want to open up, you straight away do ansa cervicalis to recurrent laryngeal nerve repair.
Okay. Thank you.
Welcome, Ezzy.
Function like we did the permanent or long-term medialization only. So if you have case like this, what should you do? What would you do? Yeah.
Right. So if this is like 1 year later, then the patient develop paralysis. Okay. I don't know. We are not sure whether it is related to thyroidectomy, or it could be coincidentally the patient has idiopathic, some viral neuritis causing vocal cord paralysis. So if you're not sure, you can just inject first and wait, see whether the nerve function return or not. If the nerve function wouldn't return after 6 months, and then the laryngeal EMG also doesn't show any signs of recovery, then you can offer permanent surgical intervention like type 1 thyroplasty or laryngeal reinnervation.
Okay. And then just so your lecture about the adaption, non-selective nervation. So the vocal cord can open, or the patient can release the breathing, or?
Yeah. According to cases that have been operated by Jean-Paul Marie that we have seen, if the surgery is successful, there would be abduction, but the abduction wouldn't be like as great like before the injury. It wouldn't like open like that. There will be some abduction, just good for the airway.
Okay.
Yeah.
Thank you. Maybe we can do like arytenoidectomy for the bilateral abduction.
Yeah. Here I don't do selective reinnervation because I don't have experience yet. And normally I do laser posterior with or without medial arytenoidectomy.
Okay. Thank you, Prof. Marina, for your
Okay. Thank you, Ezzy.
Thank you, Dr. Ezzy. Prof, did you have any experience that the patient with the, in some cases of my patient have unilateral paralysis of the vocal cord, but there is no history of infection, history of thyroidectomy or surgery, but they have a spontaneous vocal cord paralysis, Prof. If you had any experience in this in the patient like that, the patient only have a history of LPR or some acid problem in the stomach.
Okay. Before I answer that, I want to add to what Aziz's question just now about that patient delayed paralysis. If the patient total thyroidectomy was performed for cancer, you may have to do ultrasound CT scan to see any recurrence of cancer at that site that probably infiltrating the nerve. Also investigate probably other causes of unilateral vocal cord paralysis, like do CT scan of brain until the thorax. Look at along the course of the recurrent laryngeal nerve and vagus nerve. Okay, so Afiza's question, I think what you meant is idiopathic vocal cord paralysis. No surgery, no trauma, no intubation, right? So normally those kind of cases, we call it idiopathic. I've seen those cases, and according to literature, if you can't find the cause, okay, you have done CT scan, you have done chest x-ray, the patient also don't have any tumor. So you have to wait for 1 year before you offer any permanent surgical intervention. either re-innervation or thyroplasty. So within that 1 year, if the voice deteriorates, you keep on injecting, because the chance for the nerve to recover, function to recover in idiopathic vocal cord paralysis can be up to 1 year.
But
So,
sorry, Prof. But the
yeah.
patient, I also have injected the injection laryngoplasty with hyaluronic acid. It's better in 6 months, and after 6 months, it's good, going better and better after 1 year. But after the 1 year, the patient got worse. The voice is worse again. So, is there any cause like LPR or something like that that can cause the idiopathic
Okay,
vocal cord paralysis?
so the voice remain paralyzed, right, within that 1 year?
No, the voice is very good in the after I injected after I do the injection laryngoplasty, the quality is good after 1 year, and then after 1 year and 1.5 years, the voice comes worsening and worsening.
Okay, but I want to ask you, from the day you inject, during follow-up up to 1.5 years, how is the mobility of the vocal cord? Is it remain immobile, or it has returned? The mobility has returned.
Actually, the vocal cord, the patient only come to me in 6 months after the procedure that I do, the injection laryngoplasty, and the vocal cord is still immobile. And after 1 year and 1.5 years, maybe the vocal cord is also still immobile.
Okay, so we can say that there wouldn't be any recover of function. So kenapa suaranya bagus? Mungkin gelnya tahan lama. Mungkin gelnya tahan lama, okay? Bukannya kerana function yang kembali. It's not because the function has returned. Yeah. So you have injected, the voice is good because the gel is bulking up the vocal cord. Hence, there is closure of phonation gap. And when you follow up, if the vocal cord remain immobile along the way, remain immobile, although the voice is good, and then after that deteriorate, so possibly during that follow-up, why the voice is good, because the gel remained there for quite long. And then now the gel has resolved. And it is more than 1 year already. It's timely for you to offer type 1 thyroplasty, or you can offer nerve repair as well, laryngeal re-innervation.
Okay, thank you, Prof. Maybe other question from the attendants, maybe from Jimima Ling. She asks about the youngest age for the re-innervation, and also the post-re-innervation for cancer neck. How long do we wait for the post-operative radiotherapy if the re-innervation is done during salvage surgery of the cancer?
Okay, so youngest age of re-innervation, I've not done any children yet in our center, okay? But if you look in the literature, if I'm not mistaken, as young as 3 months old, people have done non-selective re-innervation. The champion in doing this in children is Julina Onkasuwan, if I'm not mistaken, and another one is Marshall Smith. Okay, you can look up the paper. Okay, so yes, the re-innervation is done in children as young as, you know, few months old. Okay, re-innervation is the perfect ideal surgery for children, because children is growing. You wouldn't want to drill the thyroid cartilage. The thyroid cartilage will be very, very soft. And you can't do type 1 thyroplasty. So either injection is suitable, or you do re-innervation, okay, in children. In cancer neck, if the patient is undergoing radiotherapy or have undergone radiotherapy, I wouldn't do re-innervation, because the radiotherapy will damage the nerve. Okay, there will be fibrosis. There's no point of doing re-innervation in irradiated neck. And the question whether re-innervation is done during salvage surgery for a cancer depends what cancer. If you are talking about total thyroidectomy in cancer with thyroid, in patient with thyroid carcinoma, yes, I do it. But if you are talking about laryngeal cancer, I don't do it. Especially if you do total laryngectomy, there's no point of you doing re-innervation. There's no more larynx there. But if you do thyroid cancer, yes, I do it, provided the site that I want to do re-innervation, there's no cancer. They have cleared it up. Okay. I have not done any re-innervation in other type of neck cancer. So the only neck cancer which I've done re-innervation at the same sitting is thyroid cancer. Okay, next question. I hope that answered the question.
Okay, Prof. The next question is interesting also. If the patient have unilateral focal port paralysis following extubation, palpating the cricoarytenoid joint is not fixed, but patient do not have any symptoms. Would you proceed to intervene by injection before the muscle become atrophy?
Yes, very good question. Yes, I would give injection. We recently, 2 weeks ago, I gave injection in a patient who developed unilateral vocal cord palsy following a fundoplication under general anesthesia. So the fundoplication, the cause of unilateral vocal cord palsy is not due to fundoplication, but due to intubation. So that why intubation cause cause vocal cord palsy? Number one is, as mentioned by Lily, subluxation of the arytenoid. Okay, but if there's subluxation, you would see the arytenoid is not in a normal position. Another theory why intubation can cause vocal cord paralysis is the cuff pressure, compressing the nerve in the paraglottic space as well as at the area of the cricothyroid joint. Okay, so normally this kind of unilateral vocal cord paralysis due to intubation injury is temporary in nature. So you give that injection while waiting for the nerve to recover, yeah, especially in professional voice users. Teachers, they need the voice. They cannot be like waiting and waiting. How long you can give them MC, medical certificate of work, yeah, lawyers, people who need the voice, okay? So you give injection. And the recovery, according to our case series, unilateral vocal cord palsy following intubation, the recovery of function, mobility occur within 3 to 6 months. Okay. And I inject with hyaluronic acid because I would suspect that the nerve function will return. So maybe we are already at the end of the session.
Yeah, Prof. Maybe the last question, Prof.
Last question.
Last question.
Oh.
From Adi Setia. How to determine the precise location of disturbance nerve? Can MRI or other modalities help? Is there any difference in treatment at the different location, Prof?
You mean in patients who have idiopathic vocal cord paralysis, I assume? Okay, so in idiopathic vocal cord paralysis, how you determine the site is by doing imaging. So you have to, but after you have done imaging, you have to follow the course of the vagus nerve and recurrent laryngeal nerve all the way from brain, in the neck, around the thyroid region until the thorax. Okay, anything that disturb the nerve. It could be like in the chest there is dilated atrium. Okay, it could be that in the lungs there is fibrosis in the upper lobe pulling the nerve. It could be that the thyroid gland looks normal, there's no swelling, but the posterior part there is nodule compressing the nerve. That can be seen on the CT scan. So the answer to that question is you have to do imaging in a patient whom you can't identify the cause of the recurrent laryngeal nerve paralysis based on history and physical examination.
Okay, thank you, Prof. Maybe this is the end of our session. Thank you very much for the amazing lecture about the focal cord, the unilateral focal cord, Prof. Maybe next month we will perform another session of invited professor. Thank you for the attendance. This very interesting topic. Thank you, Prof, for the time that you share to us about the unilateral focal paralysis. Okay, maybe this is the end of the session. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Have a nice weekend.
Photo. Let's take a photo.
Okay. Okay. Have a nice weekend, everyone. Selamat awal Muharram.
Yeah.
Oh, I can see Dr. Mariam is there, my fellow from United Arab Emirates.
Oh, I see.
Izin dokter, akan saya bantu untuk foto bersamanya. Foto akan kita ambil dalam 3 kali, dokter. Dalam 3 kali hitungan mundur, dokter. Yang pertama 3, 2, 1. Yang kedua 3, 2, 1. Yang terakhir 3, 2, 1. Terima kasih banyak, dokter, Prof.
Thank you, Prof.
Bye-bye. Assalamualaikum.
Assalamualaikum.
Waalaikumsalam. Bye-bye.
Terima kasih Prof dan Dokter atas partisipasinya. Izin saya end-kan Zoom-nya. Terima kasih.